Good morning, everybody. Buenos dias. Thanks for joining us today. We know that many people are having breakfast, so they're going to start filing in. So we're just, in the interest of time, we're just going to get started. My name is Yvonne Rodriguez. I'm the founder of Equality Sciences, but I also have the privilege of being a National Hispanic Health Foundation board member, and I'm also the moderator for today's event. Before we start, I'd like to just give some housekeeping rules. We want to remind everyone to silence their phones, and the session's being recorded, and it'll allow the audience and panelists to have a good discussion. We will also be followed by a presentation by the All of Us research program, and then transition into the panel discussion. To begin, I'd like to introduce Ms. Carmen White from Pfizer to give the intro.
Thank you, Yvonne. Good morning. I'm Carmen White. I serve as the Multicultural Participant Experience Lead at Pfizer in our Global Product Development Division. And so Pfizer's Diversity and Clinical Trials Center of Excellence and our Multicultural Health Equity Collective share the same values as the National Hispanic Medical Association. And it's through our collaboration that we began engaging with the NHMA years ago, and Dr. Rios serves as an advisory member to our collective board. And we both hold in high regard the important work and conversations like this one today, so we are very pleased to be here. At Pfizer, we are committed to achieving diversity and equity in clinical trials through 5 pillars: embedding the importance of diversity throughout our organization, expanding access and partnering with clinical trial physicians and sites to engage diverse multicultural communities, building trust and awareness in communities, and I'll get back to that one in just a moment, and addressing practical barriers and sharing our knowledge. And we hope to gain a lot of knowledge here today to share. So we do have a commitment to ensure racial and ethnic diversity in all of our trials at or above census or disease prevalence, and whichever is most appropriate in all of our trials. We also recognize the intersectionality that all cultures in the U.S. are the intersectionality of older adults, women, the LGBTQ plus community, and persons with different abilities have with race and ethnicity, and want to ensure that our messaging, education is inclusive to everyone. So we do this through our program called Breakthroughs for All, and it's our effort to foster diversity and inclusive participation in clinical trials through equitable access and best practices to reach potential volunteers and HCPs. So I want to invite everyone to fill out the form that's at your table if you have it, and my colleagues Roy and Bruno will collect them. And I'd also like to invite you at the end of the session to visit the table in the back and take information that we have our PfizerClinicalTrials.com and Pfizer Estudios Clínicos, which offers information about clinical trials as well as clinical trial information in Spanish. So Dr. Rios arrived just in the nick of time, so if you would indulge me for a moment, I would like to loop back to our pillar of building trust in our communities. So when we think back to a time a few years ago when fear, illness, social inequity, and there was an abundance of disparities and gaps that were recognized in healthcare access and opportunities to participate in clinical trials, we also recognized that it was a time where clinical trials could be a part of the healthcare continuum, and we could introduce that opportunity. So we knew that COVID disproportionately impacted the Latino community with a 2.8 higher rate of diagnoses, heightened risk, suffering severe illness, hospitalizations, and death rates. And people were seeking options and became open to clinical trials. So the date of August 26, 2020 is important to Pfizer because when we think about trust, it's important to have partners who can communicate on behalf of people to make sure that they are healthy and access to clinical trials is provided. So a radio show aired in San Diego, California, and when we were hearing a lot of information about people being fearful about clinical trial participation, Dr. Rios was one of the interviewees on that radio show. And without our request, she mentioned our COVIDvaccinestudy.com website. and we noticed a steady spike. And over 2 days, we had over 1,000 visitors to the website and 90 patients randomized. So it speaks to the importance of trusted voices providing education and opening the door to facilitate access to clinical trials. And we know with all of the research that was done around vaccines, the impact that many companies made to contribute and make our world more safe. So Dr. Rios, thank you for serving on our Multicultural Advisory Council. Thank you for your dedication and service in being a trusted partner to the community and bringing global health equity to patients who have and will in the future have access to breakthroughs that change patients' lives. So thank you. It's an honor for us to be here today and be a sponsor of this breakfast, and I look forward to the panel. Thank you very much.
Thank you, Ms. White. Next up, I would like to introduce Dr. Karriem Watson. He is the leader for the All of Us research program, and welcome.
Buenos dias. Good morning, everyone. Excited to be here. I just want to briefly this morning talk to you about the NIH, the National Institutes of Health All of Us research program. And my name is Karriem Watson. I'm the Chief Engagement Officer for the All of Us research program. And over the next 10 minutes or so, we want to talk to you about the importance of diversity, equity, and inclusion in clinical trial, but also talk to you about why precision medicine is so important, particularly for communities of color as we think about health disparities and health inequities. So when we think about the All of Us research program, it goes back to one of the largest initiatives of the National Institute of Health to develop a precision medicine initiative. And the All of Us research program is the largest program in the NIH's efforts for precision medicine. And I think we're all here today because we understand the importance of precision medicine. Prior to joining the National Institute of Health, I spent 17 years at the University of Illinois at Chicago, UIC, as a cancer disparities researcher. And one of the challenges that I would have, I did a lot of research in screenable cancers, whether it was colorectal cancer, breast cancer, cervical cancer. And although we knew that a lot of Black and brown communities carried a higher burden of cancer, our participation in clinical trials did not match the burden of disease that we carried. And so we think about precision medicine, it's really moving beyond this one-size-fits-all approach to care. Understanding that you're in Chicago, welcome to our amazing city. I happen to be housed here. But we, unfortunately, in Chicago, your DNA is important, of course, but also your ZNA, something we call Zip Code Neighborhood Association. Because just by one train ride here in our amazing city, your life expectancy can change by 20 years from neighborhood. So that means that nothing about that person changes, but something about where we live can change our health outcomes. Whether those health outcomes are changed because of our access to care, or whether those health outcomes are changed because of things that we're exposed to, food deserts and other things. So the Precision Medicine Initiative is really an effort to try to think about how do we better understand healthcare for all? How do we develop research where it's not a one-size-fits-all approach? As a cancer disparities researcher, I have a history of cancer in my family. My mother died of breast cancer when I was very young. But yet when my sisters got older, there was very little family history assessments to see when should they get screened and how should they get screened. Even as we think about colorectal cancer disparities, age and risk factors are so important, but yet we often have a one-size-fits-all approach. So what the All of Us research program is trying to move beyond that one-size-fits-all approach. So when I think about the lack of diversity in clinical trials, this is just an example here of what shows you where that diversity is. And although our Hispanic and Latino population is growing, still unfortunately makes up less than 10% of participants in clinical trials. And that number is also similar for African Americans and other race and ethnicities. And another challenge when we think about the lack of diversity in clinical trials is that when we would do what's called aggregation. We put all Hispanic and Latinos in one category. But one of the things I'm so thankful about in the All of Us research program, we recently became the largest and most diverse genomic data set in the country. To date, we've enrolled over 629,000 participants. Our goal is to get to 1 million participants. And of those, 15.8% of our participants self-identify as Hispanic or Latino. But I also want to draw your attention to the fact that we also collect race and ethnicity information because we understand that the concept of intersectionality is so important. And so imagine being able to have a genomic data set where we can understand someone's DNA, but also understand their zip code where they live, and also have information on social determinants of health as well. And the other thing that's so important is that I often say that the message matters. But the message matters, and so does the messenger. And one of the things that we're also committed to at the NIH is increasing the diversity of our researchers. So not only is the All of Us research program building the largest and most diverse data set, it's also making this data available to researchers. And we're making sure that we ensure access and awareness and availability. So I really would encourage you, if you have engagement with medical students or early trainees, to encourage them to utilize our data set to advance their research projects. And we make sure that our program, we made sure that when we launched it, it was launched in both English and in Spanish, and we're committed to ensuring that populations have access and awareness to clinical trials. These are just some examples of the conditions that we're seeing in our data set as a result of our enrollment of over 600,000 participants to date. No surprise, seeing conditions as type 2 diabetes, asthma, liver disease, influenza, pneumonia, and also kidney disease, very prevalent in the patient population. But we also collect information on social determinants of health. And one of the things, as a population health disparities researcher, one of the things that I was really excited to see is that we have information on food access, information on discrimination, information on loneliness. And this is really important as we looked at the pandemic of what social isolation does to certain communities. We also collect information through the electronic health record. So we're able to see, based on your age, based on your risk factors, based on how you completed that social determinants of health form, did you get that screening when you were supposed to get that screening? We can look at your medication list. Are you on the appropriate hypertensive medications based on age and risk factors that what we may see, and even based on genetic information that we have as well. And making this information available to researchers has allowed us to advance projects such as a research project that's done by Dr. Yvonne at the University of Miami that's revisiting the Latino epidemiological paradox and analysis of data from the All of Us research program looking at heart disease and health disparities. I'm going to run through these quickly because we're pressed for time, but I will like to make our slides available to the presenters. Also, this is another partnership that we have in Ponce Health Sciences, working with Dr. Nomarie Torres Blasco, where she's looking at All of Us data to develop an empirical model for social determinants of health, as well as Hispanic and Latino with mental health conditions. And in terms of our safety and security, I recently, in February, was in Tuskegee, Alabama, in Macon County, because we take trust very seriously. And the reason it was so important for us to have a town hall in Macon County, Tuskegee, Alabama, is because when you think about reasons why certain communities don't participate in research, it's often because of lack of trust. But we often like to say it's lack of trustworthiness, because lack of trust puts the onus on the participant, but trustworthiness puts the onus on us to say that we have to become a trustworthy entity and a trustworthy partner for populations to participate. And our data is available in a publicly available data source, as well as a registered tier and a registered tier and a control tier data set, which we can talk more about. And again, the data includes electronic health record information, genomic data, survey data, and even wearable data that's available to our researchers. And making sure that we return that data back to our participants is also something that's very important. I'll end with letting you know that anyone who participates in our study, if you get genetic information, we actually will connect you with a genetic counselor. And the reason why that was so important, because we know in several communities, people do not have access to genetic testing or genetic counselors. So the results that we return back to participants, they actually get connected to a genetic counselor to be able to better understand their condition and what conversations they should be having with their healthcare providers. So I encourage you all to scan here to learn more about the All of Us research program. There's my email. We're going green in the federal government, so we don't have cards right now, but please, my email is there, and I would love to hear from you all and love to see how we can partner with you and your organizations to increase both the diversity of participants in clinical trials in general, but also to increase the diversity of researchers conducting clinical trials. Thank you all so much.
Thank you, Dr. Watson. So following, we will have our discussion with our panelists. I won't, in the interest of time, I will put their bios up for display. However, this is going to be like a fireside chat, so the audience is welcome to participate. I do have questions for our panelists that are based on topics that we will present. And while our panelists highlight importance of each topic, we also want to hear from each of you. So I'd like to go ahead and introduce Dr. Mora and Dr. Gomez, both clinical trialists with a lot of experience in research. Welcome. So can everybody hear me? Okay. So one of our first options or discussion points for today is to have clinical trials as an option of care. So we'd like to ask, how do you feel about clinical trials as an option of care? And do you have colleagues that feel differently? If so, do you have any suggestions on how to address this, not just with colleagues, but with patients? I can have Dr. Gomez answer first.
Hello. Okay. Yeah, I suggest that, people engage in clinical trials, and clinical trials are a good option for healthcare because most of the patients, they don't have, the access to good healthcare. And especially, I'm endocrinologist and diabetic patients, they lack of economical, sorry, the financial, means to buy insulin and all the medications and supplies that they need to control their disease. So the clinical trial give the opportunity to have all those things, plus education. And I think I very encourage, new colleagues to enroll in clinical trials because it's a good option for medical practice. When we graduate from medical school, we have the knowledge, but we don't have the experience. So throughout the path, we have to connect all those dots because they will make a difference, they will make sense. And clinical trial give you that opportunity to connect the dots, to apply knowledge into your clinical practice, and it's a good experience, for everybody, for the doctors and for the students also.
Thank you, Dr. Gomez. Dr. Mora?
Buenos dias. Thank you very much for the invitation. I was very, very impressed with Dr. Watson's presentation because he mentioned something that I think is very important when we do research with Latinos, is that the patients or the participants need to trust us. And I want to develop that idea because it's something that I think you guys have to understand. For years, all of the Hispanic or underserved, for that matter, underserved populations were only being basically participating in clinical research from academic institutions. And that has been a big problem because the academic institutions usually sit in the big city and they only carry that participation from the people that are underserved in the big city. And one of the things that we found, for example, in Dallas, is that there were areas which were not necessarily served by the academic center that we, as a private research institute, went out and specifically partnered with one of those low-income clinics that there are in many of the cities. So that's one of the things I want to emphasize, that this is a very, very important way to break out of the box. So instead of us relying that these patients are going to come to the big University of Chicago or the big University of Texas, they have to be reached out. And the way to reach out is exactly like Dr. Rios and you guys did it. I mean, you get on the radio and you talk to them in Spanish and say, hey, we actually talked the same way that you do. We eat the same things that you do. We all look different colors and different things, and if we're from Puerto Rico, we eat completely different than if I'm from Costa Rica and so forth. But we get it. We get it that you're different. So my suggestion is that we also break away from academic-based minority, if you will, research, because the reality is that we're not going to be the minority. We're actually going to be the majority of the participants. So the clinical trials have to reflect that composition. And I'm very, very pleased that the NIH really is peeking into this. We need to reach out to the community, and the community has to trust us. And I think that's what I take from Dr. Watson's presentation, very, very close to heart.
I'll take it from a very personal stance. Why diversity in clinical trials and why access to clinical trials is so important. I could not agree with you more. Two examples that stood out for me is that I'm from a small town in Michigan, and despite the fact that I'm a cancer disparities researcher and I have access to a lot of clinical trials and a lot of doctors, when my mother was diagnosed with lung cancer, she was in a small town in western Michigan and not at a big academic medical center. So there were no clinical trials. And before they treated her for her chemotherapy, I had several questions about, did you test her tumor for molecular targeted testing? Because I knew, as a cancer disparities researcher, that clinical trials had advanced what we're able to do in lung cancer treatment and screening. And I knew that there was a new medication out there that was available through clinical treatment trials that I wanted her to at least be tested for. But I had to educate so many of the providers in the healthcare people providing her care about the importance of clinical trials. I had to educate my family about why it was important, because my family's from the South, and so they use words like, well, we don't want her to be a guinea pig. And I had to explain to them the importance of at least seeing if this was an option for her. And while a clinical trial was not an option for her, she did qualify for an innovative drug that had just came to market that many people would not have been aware of. And that innovative drug extended the quality of her life. It allowed her to have a shared decision about, but she would have never had access to that medication if I didn't advocate for it. You shouldn't have to have a son that does cancer disparities research for you to be able to get the best and innovative care. And so part of the reason why I'm excited that all of us research program has over 47% racial ethnic minorities enrolled in our program, because it's my job as a chief engagement officer to make sure that our recruitment sites include federally qualified health centers. It includes community clinics, but in order to include these clinics, you actually have to train and educate the physicians on why that's important and understand that research is not their primary job. Patient care is their primary job. So how do I come in and not disrupt that care, but become an asset for them to advance that care?
Yvonne, can I ask Dr. Watson some question, because this is very interesting. So my take is that within the disparities that we have for the Hispanic community, there's inside that disparity, there's a disparity between women and men. So can you speak a little bit about that? Because at least from diabetes and men is rather so hard to recruit because of the time constraints, and women, they don't have time either for other reasons, and the approach to them is completely different. So have you guys identified that disparity within the disparity?
Yes, for sure. And briefly, one of the things, as I said, my research actually focused on minority men. And so before, when I was on the outside at the universities, telling the NIH that I was going to do a large clinical trial to recruit African-American men into a lung cancer screening program, several people said, well, Karriem, black men are hard to reach population. And I was like, oh, first of all, I am a black man. I'm not that hard to reach. I think it's more about, again, the messenger. And I work with barbershops. I work with fraternities. I work with pastors. And I often say, when it comes to clinical trials for men, go to where the men are. But also, another thing is I work with women. I do a lot of work in the African-American church, and so one of the things that I do in the church, the reason I'm successful, is because I don't go to the men, I go to the pastors and I go to their wives. And their wives are the change agents that allow me to get access into communities where I normally would not get access. But we have to, again, have conversations about where does that mistrust come from. I was in a taxi car, and I try to live and breathe this work. So my taxi driver was, and we were in Florida at a conference, and he was asking me what we were there for, and I said, well, have you been screened for colorectal cancer? And he said, no, I don't want that. And he said some things about the, very machismo, very hypermasculine approach to this. And I said, that type of approach will not. I said, do you have children? He said, I do. And I said, do you have, and he said, I have a daughter. I said, well, that type of approach will not allow you to be there for her wedding one day. That will not allow you to be there for major events in her life. So as men, we have to get beyond this fear and really understand we have to do things to be there for our families. So.
And, one more comment. In regard the guinea pig idea, the colleagues also think that way. Some doctors, they don't want to enroll in medical trials because they don't want to get involved in humans with experimenting drugs and that. And the same thing, patients think the same way. And I think we have to, the role of us is to educate these people and, tell them you're not guinea pig. You're contributing to humankind to develop more drugs that maybe in the future, these drugs are gonna be good for your family and are gonna save lives also. So, that idea we need to change in the population.
Thank you so much. Oh, we have a question.
Dr. Aguilar, Cano Health in Florida. You're absolutely right about recruiting patients. We began enrolling patients in a clinical trial, COPD, smokers, and just this year alone, enrolling in CT scans and markers, 3 patients were picked up with early stage lung cancer, which would have not been picked up otherwise. So getting them into these clinical trials does 2 things, as you well stated. It affords them an ability to get testing or treatment or workup or education that they wouldn't normally have gotten, and it helps bend the curve on clinical outcomes because we're able to detect things, whether it's colon cancer or lung cancer. So needless to say, these 3 patients were extraordinarily pleased, and so were we, about detecting early lung cancer in these patients. So it makes a big difference.
Thank you.
And Yvonne, can I add to that comment? I mean, in clinical trials, we find a lot of other things that we were never looking for. I mean, every year we ended up sending patients for workup, and then they have undiagnosed cancer, they have undiagnosed other conditions. Heart disease is very frequent. The chances for a Latino patient that lives in an underserved area to get an EKG and a chest X-ray is very little, unless they're sick with something. And in clinical research, we pick up a lot of those little things. So, I mean, you mentioned it earlier. I think one of you mentioned earlier that clinical research is a way of medical care. It's just how do you actually present it to the patients and make them understand that it's fine to go and live in clinical research from one trial to the next one to the next one. And we offer, even if they're doing diabetes clinical trials, we offer lipid management, we offer smoking cessation. We ask them, hey, when was the last PSA that you had? And we might not do it because it's not paid by the clinical research, but we'll send you to a clinic, or we find you a program. So I think that the potential for this to be a form of medical care for especially the Latino population in certain parts of the country it's huge.
Thank you so much. Well, actually, moving on to a similar topic about cultural competency. And so what feedback do you have for any colleagues that are new to research regarding cultural competency?
Yeah, I often use the word cultural sensitivity because for my colleagues, I tell them that cultural competency is not a destination, that it's very difficult to be fully competent in another culture if you're not a member of that community. Although our program did an amazing job at ensuring that our program was in English and in Spanish, I had to remind them that there's different dialects. And so when we translated our materials in Spanish, and we enrolled sites, and then we went to Puerto Rico, our team told us there, this may not translate here. So we have to think about that. But the reason why we were effective in that, because my team reflects the populations that we serve. And I think we also have to we talk a lot about diversity in clinical trials, but we also have to think about diversity in researchers and diversity in the research staff. And one big piece of cultural sensitivity and cultural competency is having a team that reflects those that you're going to serve, because we bring our lived experience to this work. We bring our full selves to this work, and if you have a diverse team, that team can understand the culture of populations that you're serving. And so I think we have to bring that and be it in a non-judgmental way. We talked, joking about certain things. When I would go certain places, I would bring my colleagues. I say, we might start a little late, and that's going to be okay. It's no judgment to that. You know, I said, or we may go off script. I said, this is all cultural. I came to a clinic that was an urban American Indian clinic, and when I got there for my presentation, it was set up in a very teacher-type format. I immediately told my team, well, we got to change this culturally. This is inappropriate because it created a hierarchy in that, and that's this community. We can't have a hierarchy, so we put the chairs in a circle. I only knew that because I had a colleague and a friend that was American Indian that told me from a cultural sensitivity perspective that that circle would be a better way to have a dialogue than the way the chairs were set up. So it's so many nuances to culture and cultural sensitivity.
And I don't think you have to belong to the culture that you are serving to understand it. Let me give an example. For me, one of the most difficult parts of the year is Ramadan, because Ramadan really, really impacts the way that we do insulin, especially, and the way that they eat. And this is kind of reverse counter cultural competency for me, because I have to remind myself that this is very important for them. And I have to adjust everything around the Ramadan month to make sure that I work with that. The other thing that is also funny is that you don't really have to embrace everything that the Hispanic community likes. For example, the joke always is, we're huggers. And my patients and my research patients also very frequently like to hug you. And I mean, you don't have to really enjoy the hug necessarily, but you have to understand that it's part of our culture. Touching the patients is very, very, it's for them is an extension of the healing process. And when you start doing research for these communities, you have to understand. The opposite is true for certain communities in Asia. You have to be really careful. Who do you hand your hand to it, especially for women? So it's complicated, but I don't think that we have to be part of that culture necessarily to be competent on or sensitive. I think this is a better word. Sensitive to that, what they need. And if you don't feel like you need to hug everybody, that's fine. They will understand. They will just look at you and say, yeah, thank you.
Also, I think for the research competence or cultural, sensitivity, it's, and I'm gonna get a little bit off. Yeah. For the sponsors, they request, in my experience, in Puerto Rico, we don't have too many Black Americans. So it's very, I think less than 1% of the population are Black Americans. So they request us to enroll Black Americans. And it was very difficult, very difficult. So we consider Black Americans the Dominican Republic people and also some Cubans, and but it was difficult. So I, also made the sponsors to be more sensitive in that matter, because in some regions we don't have representation of all the cultures, like Asians, like, in other areas could be Hispanics and, Caucasians. So we had to, think about the area that we have sites for clinical trials to request those special cultural needs or ethnicities.
So I want to add also another thing for the sponsors that I think and correct me if I'm wrong, but I have the feeling, at least in metabolic disease, that being first generation Hispanic versus being second generation Hispanic is going to make a big difference. And we know, for example, in Asian people that have immigrated from either Korea or Japan or India, the rates of diabetes are completely different than when they are first generation than when they're second generation. So I am guessing that with the help with the NIH and a lot of people, the sponsor needs to start figuring it out. It's not the same if you are here for 20 years or you were born here 20 years ago. And also, culturally speaking, my kids were born here. Even though they swear they are from Costa Rica because we have dual citizenship, they're not. They're like 60-40. 60% gringos and the other 40 is what her mothers and their mother feeds them, okay? So meaning that we feed their culture, our culture into them. But it's not the same like myself, that I come from a country, for example, that has one of the highest incidence of gastric cancer, to give you an example. So I know that my gastric cancer risk, to Dr. Watson's point, is completely different than them because they were born here. So being first generation versus second generation is not the same story. And especially I think in cancer and metabolic disease, because the exposure to the environment.
Yeah, commenting on that, sorry. Yesterday I was one of the conference, and the pediatrician, she's a pediatrician endocrinologist, and she said that it's not the same rate for diabetic population living in Mexico than when they move over here to the States, double the percentage of the diabetic risk. And you know, that surprised me. And today, when you, Dr. Watson, talk about, you know, ethnicity, the DNA, the percentage, the gender, you know, those things are different from areas, from, you know, Chicago to Puerto Rico, from Puerto Rico to Dallas. So they're very different. And, you know, environmental things are impacting the different diseases, because it's not the same pollution, is not the same here or the same in Puerto Rico. So also the diabetes type 1, you know, has increased because all those pollutant environments, and it's, you know, sometimes I think when we went to medical school, the things they were very different. Diabetes type 1 was autoimmune disease, that's it. But today is completely different etiology, and environment has to do with it a lot.
Let me give an example about type 1 because this is my area of interest. Type 1 was a Caucasian disease, basically. And we had like very few, relatively fewer Hispanics, but they were of Caucasian race more than anything else. One thing that has changed, at least in our experience, is COVID exposed everyone to this viral insult. And we're seeing a lot of type 1 that is probably, we think, in somewhat related to the exposure to a viral load and created an autoimmune. So my take is that you're going to see that the type 1, just as an example that Dr. Gomez was saying, is going to change. So the type 1 that we trained on is going to be a completely different type 1, and it's because an environmental change. And so I'm guessing probably some of the cancer behavior is going to be the same, because COVID really kind of wrecked out everything and kind of reset things. So we think that moving forward, these specific diseases are going to also behave differently.
Also for the criteria, you know, in clinical trials, we have criteria to enroll patients. And I think the criteria has to be changed also, because now I'm conducting the type 1 and type 2 diabetic clinical trial, and I had seen a lot of the late onset type 1 diabetes, the late onset type 2 diabetes. So it's like 26-year-old becoming a type 1 diabetes. You know, before it was not that common, but now you can see a 30-year-old, 31-year-old being diabetic type 1. So that has changed a lot. And these people are being treated as type 2 diabetics. So it's very difficult and very scary because those patients, if we don't diagnose it well, they can end up with DKA, in coma, or death.
Thank you so much for the comments. So our next topic is to focus on community physicians. And my question is, what is your ask from sponsors listening today that can help the community physicians be more involved in clinical trials?
One piece is training. One of the things that, as I said before, medical schools don't have curriculums. They're growing now to have Masters of Science programs that can train clinicians to become clinical trialists or become principal investigators. But many community physicians choose that specialty because they want to provide care in communities that are historically underserved. And so one of the things that sponsors and the NIH and others need to think about is investing in those community clinics early on. It's going to take relationship building to get that community clinician ready to become a PI. So, principal investigator, so you may have to do some investment. Think about training, continuing medical education that can support them in thinking about what role do they want to play in the clinical trial space. That community physician may not want to be a principal investigator. They may want to be someone that talks about the importance and awareness of clinical trials. And so I think we have to invest early on. We do a lot of work with medical students and a lot of work with graduate students to get them aware of the importance that no matter where you practice, because again, to change this concept and not to hold community clinics to the same standards. When we do site visits and everything, yes, we have to have the quality there, but to think that a community clinic is gonna have the same resources as a big academic medical center is unrealistic. So how do we provide those community clinics and that community physician the resources they need to be an equitable player in the clinical trial space?
And a call for the sponsors also, because just to give you the one disease that I think is very difficultly represented because of the cost is obesity. So obesity trials now are focused on this GLP-1, GIP agonists, which are, I'm sure you guys, if you watch the Oscars, they talk about Ozempic. If you watch anything, they talk about Mounjaro and so forth and so on. The point I'm making is that probably 60% of the population will never have access. The population that needs it. Like we're talking about the African American population and the Hispanic population that is underserved. All of these people are never gonna have access to that. So the sponsors need to find a way where they make clinical research a way for them to be able to access that medications. I don't have a solution, but one of the ways to do is to actually, instead of going and putting all the trials in academic medicine, academic institutions, go out there and then make a day where you engage with a community clinic and then find out. There's always someone who is the champion on the community center about something, either for family reasons or for personal reasons or whatever reason. There's always who loves diabetes, there's someone who's expert on cancer or something. Take those people and nourish them and tell them, hey, if you want to do something, we'll enroll you as a sub-I to begin with on a small little trial, or we'll send you to some training. Nothing is, to my knowledge, nothing is done consistently in the communities other than the academic centers going out there because they want the patients, or NIH or bigger groups, ADA, JDRF is doing some of that. But I think that the sponsors have the role also that they're not playing, which is extending that to the community.
Well, I'm a private investigator. I don't belong to any institution per se, as university or NIH or, I'm private. And the way that I started my clinical trial experience was right, after I graduate, I want to do something different, and I was always very curious about research. But there wasn't any opportunities for fellowship to engage in that area at the time that I was trained. not now, because now I know the fellows, they have experience, they expose them to research. But at that time, it wasn't. So, I found a way to contact the sponsors and, to let them know, hey, I'm interested in doing this, and they opened the door for me. And I think they don't regret. I've been participating in clinical trials for 15 years, and for private sites are a little bit difficult because we don't belong to universities, and probably academically they think it's not the same quality of research, but it's not true. I mean, we are doctors. Whether you belong to an institution or you're at an STEM-free practice, so we are doctors. And that's the main point, and that's the main thing. If you want to participate in clinical trials, you just go ahead, step out front, and ask yourself and ask the sponsors that you want to participate. And the sponsors, they have to give the opportunity to these new people that want to enroll in trials. And as Dr. Mora says, that's another second point, the research is costly for sponsors, but they have a lot of funding also. And they have to create a way to make these medications available after the people is, enrolling in the trial. Because when they are in the trial, they're very happy, everything is cream and peaches, so it's wonderful to have these medications available, this kind of care, but after a year or so that the trial is over, what next? And that's the problem. I was a participant with the tirzepatide, the Monjaro, and they approved it for diabetes. And, now we know that they're in the way to for the obesity. But the patients, they cannot afford $1,200, $1,500 a month, which is the cost of the medication. And insurance, they're not gonna pay that kind of money, for that medication. So it's gotta be a way to make these good medications, because they're excellent medications for the patients. After they enroll in the trial, and patients that are not enrolling in the trial also, to make them available, to make these medications reachable for patients. It's gotta be a way. Legislation, the society in Puerto Rico, they have a committee where few years ago they approved insulin pumps for every type 1 diabetes. The diabetic patients, they didn't have that access before. And now the society, they fought a long way with the government, and now it's approved. And also the insulin and the supplies, because they approved the pump, but how about the insulin and the supplies? It's like you cannot go without them. So it's a fight that the society has with the government, but we're winning we're winning the war, so it's a good thing. And I think this kind of engagement with the government, we need to be more upfront. We need to speak up more for financial purposes on the patient, to favor the patients, especially, I'm saying especially the diabetics because I'm endocrinologist, but I think, cancer patients and everybody's disease is very important.
Thank you very much. I would like to ask for each of our panelists to add some closing remarks. So I'll start with Dr. Watson.
Thank you so much. First of all, thank you for this opportunity. One of the things that I want to close on is really encouraging associations like this to think about really reaching out to how can we increase, yes, the diversity of participants in clinical trials, but also the diversity of researchers. I can't stress how important that is. And even because when the design of studies, one of the things I love about our All of Us research program is that as a researcher, I would get communities excited about trials, and then community members would come back and say, well, Karriem, I tried to enroll, but I don't meet the criteria, because oftentimes the design of studies will exclude populations who carry the greatest burden of that disease. For blood pressure and other things, they're often excluded. But when we have people designing the studies that are from these communities, we understand how to design the studies in a scientifically rigorous way that can still be safe and effective, but also inclusive of those populations. So I think really encouraging both diversity in clinical trials participant, but also in diversity in the clinical trials workforce is really something that we want to drive home, and also thinking about how can we start the conversations earlier. It's great that we're here talking to physicians, but I love too when we're talking to high school students and medical students to expand their career options, to let them know that a career in research is an option.
Thank you. Dr. Gomez?
Well, I have many conclusions, but I think the most important is if we want to participate or be a clinician in investigation, we have to remember that we are physicians first than investigators. And remember that we have ethics to follow. The good clinical practice and the protocols, they are there for us to be guided by them. But we need to use our clinical knowledge and decisions for these patients that we are caring about. Because clinical trials are good for patients, good for clinicians, but are also a way, of medical practice. And you are entitled to, to do a good medical practice. And remember that patients can suit you also, even though if you are a researcher. So that's very, very important, to have in mind and have in consideration researchers, medical.
Patient safety
Yeah.
first.
What I want to propose as one of the things that we move forward with some of this is that, we set the expectations correctly for the clinical researcher also, the person that wants to start. This is not something that you look at your schedule and you say, okay, I have 2 hours on Wednesday from 1 to 3, and I'm going to do clinical research from 1 to 3. That doesn't happen. This is a career. So you have to understand that even though you may be doing research 1 day of the week, you're actually a researcher the entire 7 days of the week. So make sure that we set the expectations correctly when we start this, but also at the same time, make sure that we give them the resource. So I was talking to Yvonne about that I'd be very happy to offer time if anybody wants to call up and say, hey, how do you start in the beginning? How do you do this? How you do that? And then what the heck is a centrifuge? And what is the minus something freezer? And where do you put it? And what is the lockup thing? So we want to offer some of those resources moving forward.
Thank you, Dr. Mora. And we will have resources for you shared with you after this session. Before we close today's session, I'd like to play for you a real-world example of patients that are depending on Hispanic physicians. And with that, you can go ahead.
Hello, my name is Marco Perez. I'm 39 years old from El Paso, Texas. I was diagnosed with testicular cancer back in March 2021. During that time, I had not been to any kind of doctor, had any kind of visits, medical treatment, due to the point that I didn't have insurance. it just wasn't in the card. And trying to pay out of pocket is something that it's kind of difficult. But I finally went to the ER, and I found out that I had a tumor. Um, I I spent 3 days in the hospital and got my left testicle removed. After that, I was I was given the information to go to a specialist, but once again, due to the point that I have no insurance, it was going to be somewhat difficult. Um, but because I had no guidance, I really didn't know what to do. My sister tried to find some kind of trial or some kind of help for me in my community, and there wasn't. We were told that I would have to travel to Houston, Texas, which was it's a larger academic center, but I would have to pay for the trip, the medication, basically travel, stay, everything out of pocket. The worst part about that was that it's not in the cards. And finally, when I did happen to go through chemo, I had to go almost for a whole year, every other week, and it, it was something else. Um, I am in remission today, but I still suffer from a lot of associated conditions due to the cancer. Um, that they've affected my life really, really bad. My sister helped me. He's helped me where I believe I was left in the dark, information-wise. He's helped me with everything else that we could really that I've used. But I know that for a fact in the Latino community, we're raised to work. We're raised to continue working. Slowly we start breaking down, we start falling apart. But it's the way generations have taught us. Nos creyeron así. We were raised that way, and we were basically made to just continue working. You do it for your family, you do it for your loved ones, and just keep going. And I feel now more than ever that these next generations need our help because they are left in the dark with their problems, and some people don't know where to go or how to deal with it. I would like to ask you not only to consider being a principal investigator, but also to consider encouraging your colleagues to help people like me in your community. There's a lot of them. I know that some people have gone through a lot, and clinical research is a win for all of them. Our community regards you guys as trusted leaders. Like your participants, the people you help in the community will get the ability, like they'll get the cutting edge medication and treatment that they can't get anywhere when they have no insurance, they have no other option. They're left alone. I was like learning more about treatments or what may work for them. No one helping participants. Like it affects everyone, not only the person itself, but affects their families, affects our generations to come. And all we're asking for is health equality. Like I would really like to ask for you to consider this a call to action. Ayúdenos. I know you're interested in taking part in clinical trials. And I gotta say, like, yo sé que yo no puedo ser el único. I'm like, there has to be other people that have suffered the way I. Thank you for your time and your consideration. Gracias.
Thank you very much for your time today. We hope this session has brought further insight and inspiration for you to take part in medicine's development for your communities and for future generations. We will share the panelists' information with you later today. Please feel free to reach out as well to us after the panel end. Thank you very much.
Yvonne, can I just make a comment? I'm Elena Rios, president of the National Hispanic Health Foundation, and many of the sponsors sponsored this for our clinical trial project that we have. We call it the National Hispanic Health Research Center, or National Center for Hispanic Health Research, and our goal is to develop our database. We've started a database of Latino PIs in clinical trials. That's how we found you. We are very excited about also being a national partner with the All of Us research program and with Pfizer, who was Carmen White, who welcomed us this morning. But I want to just mention to everyone here how important it is to think about your comments, especially on the survey. We want you to sign the pre-survey, and there's a QR code on every table for the post-survey. And even if you're not a PI right now, what kind of information as a physician with with patients, what kind of information about clinical trials can we provide as a new project? We would like to be able to provide referrals to training programs, to All of Us research program. One of our sponsors, and I know we have many sponsors here, but one of our sponsors is Amgen, who is going to be starting a Latino-focused and minority-focused training program for young doctors. So we need to think about our next generation and working with our companies, sponsors on our corporate advisory board of NHHF and NHMA, to be able to help them with the referrals through our networks. And as you mentioned, Dr. Gomez, you beautifully put that you're not part of an academic institution. 90%, 80% of the Latino doctors in this country don't work for academic institutions. Many of the doctors that come to our conference are from academic institutions, but the rest aren't. And I think we're gonna have to go on the road to find more private doctors through our chapters, maybe taking this conference to different cities where we can find more private doctors interested in sharing the knowledge that we do have as Latino physicians on how to better attract, recruit more patients. And I want to give kudos also to Cano Health, who's here, because they're a major minority Latino private practice. And I'd like to just say one other thing. The doctors in clinical practice and in that can be in clinical trials don't all have to be at community health centers. And I know you mentioned that that's I think we get a focus of community health centers because the federal government supports community health centers. There's got to be a way for the federal government to help support private practice doctors, especially as they get involved in clinical research, which is really connected to the federal government purpose. It's now the FDA who's mandating that there should be more diversity within clinical trials, and I know the FDA is here. I think the FDA needs to focus a little bit of more training on how we can help our doctors get engaged in clinical trials too. And I'll just say one last thing. We did apply for a grant from the FDA for training of, not training, but for identifying the doctors who could be mentors. And Dr. Mora, thank you for offering to have mentoring program within the clinical trial space that we can do because of our networks. And Yvonne, I just want to thank you for moderating this and bringing everybody together.
Thank you.
Thank you.